Good evening, everyone. Welcome to the final session of Mini Medical School. My name is Tim Gibbs, and I'll be your co-host for this evening, along with Dr. Kate Smith. So these last 6 weeks, we've covered trauma-informed care, breast reconstruction, sports medicine, telehealth, the science of anesthesiology, and this week, childhood development with Dr. David Paul, who Dr. Smith will introduce momentarily. I wanted to thank you all for attending the series this year, and also to point you to another resource, which is the Delaware Journal of Public Health. It's djph.org. It's open to all. Our latest issue is about vaccine preventable disease. For you students in the group, it might just be a great place to go and look if you're researching an article. You might find something good there. It's free, you don't have to be a member. It is there for everyone's use. Dr. Smith, I'll turn it over to you now. Thanks, I hope you have a good evening.
Thank you, Tim. I'm going to go ahead and share my screen again. As Tim said, welcome to our last session. Who would have thought we'd make it all the way here? Thank you so much for sticking with us and telling your friends and signing up for more sessions when you realized how much fun they are. We really do appreciate it. We hope you enjoyed it. We hope you got something out of it. We will add your emails to our mini-med list, so we will be able to let you know of the next session. When we know when it's going to happen, you'll know when it's going to happen, and hopefully you'll be able to sign up for that too. And this session, as always, will be uploaded to DelawareMiniMed.org once we get that recording all squared away. Tonight after class, you are going to receive an email with a link to a survey. When you complete that survey, that will be the final attendance piece that we need for class. You have until 8 o'clock on Monday morning to complete it. So you've got all day tomorrow, all weekend to complete it. And once that happens, later on next week, I will send out an email to those of you who attended all 6 sessions. You'll get your certificate. But as always, for tonight, please make sure that you count yourself as present by either putting your name in Zoom. If you're on Zoom, put your name in the chat. If you're on the phone, please email me with the word of the day by 9 o'clock. You don't need to do both. If you're on Zoom, I don't need the email with the word of the day. I just need one or the other. And the word of the day is last, because it's our last night together. But last but not least, we have a really great presenter tonight. We have Dr. David Paul. Dr. Paul is appointed the chair of the Department of Pediatrics at ChristianaCare in June 2014. He earned his Bachelor of Arts degree from the University of Colorado and his medical degree from Hahnemann University. He completed his residency in pediatrics and a fellowship in neonatal perinatal medicine at St. Christopher's Hospital for Children in Philadelphia. Dr. Paul is a professor of pediatrics at Jefferson Medical College in Philadelphia. He has been a practicing neonatologist in the community since 1994, serving at Christiana Hospital and Alfred I. DuPont Hospital for Children, as well as several other hospitals in the state. A champion for the prevention of infant mortality, Dr. Paul has led the Delaware initiatives to decrease infant mortality and premature birth for over a decade. Since 2005, he has served as the governor-appointed chair of the Delaware Healthy Mother and Infant Consortium. So I will stop my share. I will ask Dr. Paul to unmute. And Dr. Paul, the floor is yours.
Thank you, Kate. I greatly appreciate the introduction. And Tim, can you guys hear me? Have a thumbs up? Yep.
You're good.
Great. And let me try and share my screen here. Okay, can you see the screen?
Yes, I can see your screen. It's the it's not the presentation mode. It's just the now I can see the PowerPoint. Yes.
Okay.
Except we can see your presenter mode, not the full screen.
Not the full screen.
Still presenter mode.
No, I can't see a thing. Hold on. Yeah, I'm not sure why that's happening.
Do you have a dual monitor?
Yeah,
Or
I do.
So you might be sharing the other monitor. When you go to click share screen, do you have an option of which monitor you can choose? Well, no, that's the other
Okay.
monitor.
Stop there. Sorry for the difficult to share screen.
That's okay. Worst comes to worst, I can just advance your slides for you because you sent them to me early.
How's that?
That looks good.
Okay. All right. Thank you, guys. Sorry for the technical difficulties. Thanks, everybody, for joining in tonight. I really appreciate such a great crowd on a weekday night. And so over the next hour and a half or so, I'm going to review typical development, including some of the new CDC milestones for development, discuss some medical, environmental, and social conditions that may negatively influence development, and then really discuss interventions that have, some interventions that have the potential to improve development. It's important for everybody to know that I'm a neonatologist. I take care of babies and not a pediatrician who takes care of children over the long term. And so that's going to be my orientation towards this talk. So I was asked at the beginning, and I see many of you are high school students and college students, to kind of go over my path and how I got here. And I think everybody has a unique and a winding path into medicine. I grew up in Pittsburgh, and I would say I was an average student in high school. And when I look back on it, one of my most important experiences to going into medicine was my first job at age 16, bagging groceries at the Giant Eagle. And after spending a summer doing that job, I decided I don't want to do that for the rest of my life. And so I went to college in Colorado, as Kate pointed out. I really applied myself. I really liked biology. I went to medical school in Philadelphia. And then at the start of my pediatric residency, I really decided I wanted to be a cardiologist. But a few years into it, I was in the neonatal intensive care unit. I loved taking care of babies. I had a real passion for it. And I changed paths at that point and went into neonatology. So I'm probably, if I would have sat around when I was many of you guys' ages in high school or college and said, I think I want to be a neonatologist in Delaware, I don't think I would have ever gotten here, but this is where my path led, and here I am. So let's talk about development. Can you guys see the transcript at the bottom here? Or is that just me? Kate?
Yes, we can see the transcript.
Let's try to get rid of that. That's bothersome.
It's really okay. We have another transcript running too because we have some harder of hearing folks on the line.
Okay, all right, we'll go for it then. Developmental milestones are defined as, and let me just back up. The first part of the talk I think is going to be a little dry as we go through definitions, and the second part of the talk I think we'll really get into the fun part of childhood development. But developmental milestones are described or defined as behaviors and physical skills seen in infants and children as they grow and develop. So some examples of developmental milestones are crawling, walking, smiling, and talking. And we'll during the talk about when those things occur in children. It's really important to know that there are normal ranges in which children reach these milestones, but every child is different. Not every child develops differently, and we'll start to explore some of the reasons why children develop differently. As a pediatrician, our field, we routinely assess childhood development with almost every well-child visit, so it's something that pediatricians do very routinely. Okay, now my slides aren't advanced. Okay. When thinking about childhood development, what parents really want to know is what is typical. What is typical in development? And as a neonatologist, I talk to parents all the time of sick babies, and what they want to know is, you know, how's my baby going to be 5, 10, 15, 20 years from their birth? And it's something that's very difficult sometimes to predict or describe. At the bottom is a typical bell-shaped curve. And just like anything with height and weight, pediatric or newborn development is a bell-shaped curve. So we know that some people are heavy, some people are thin, some people are tall, some people are short. And that's the same for development. And so, for example, 50% of children may walk by age 1 year. 75% may walk by 18 months. Some children walk at 10 months, some take a little bit longer. And so as we go through this, keep this bell-shaped curve in mind. There's really not one normal or one way you can describe development. Everybody kind of has a different path. Pediatricians, I mentioned, frequently assess development, and pediatric primary care is used by almost all families. And when I say pediatric primary care, that's your pediatrician or your family practitioner. And I'm sure almost everybody here has gone to a pediatrician for many years. Pediatric providers frequently assess development. And if development's abnormal, that gives a pediatrician the opportunity to refer children for more in-depth evaluation or to connect families with needed services. And we'll go into more detail on that. Pediatricians assess development in a number of ways. One is something called developmental surveillance. And so there's a list of milestones, and there's these new milestones and publications by the CDC and the American Academy of Pediatrics that I'll review. So every time you go into, a child goes in to see a pediatrician, they are surveilling a child's development in some ways. And it may be just through in their brain by looking at a child's development or asking questions, or by doing a physical exam to note if a child is developing their motor skills normally. Pediatricians also do more formal screening. And so the American Academy of Pediatrics recommends that formal developmental screening and behavioral screening occurs at 9, 18, and 30 months. So again, every time you go into a pediatrician's keeping development in mind, but these formal screenings will be done at 9, 18, and 30 months. And there's many typical screenings that a pediatrician can use. One is called the ages and stages. That's very typically used. The American Academy of Pediatrics also recommends that formal autism screening be done at 18 and 24 months. And so one formal autism screening that's used is something called the MCHAT that would be done at 18 and 24 months. I mentioned the CDC and the AAP new milestones for development. So let's start to review those a little bit in detail. These were just published a few months ago, January 2022. And again, the CDC and the American Academy of Pediatrics jointly came up with these milestones. You guys don't have the slides. If you had them, you could go to the link here to look at them. But there are 4 categories of general development that are described in these milestones: social, emotional, language communication, cognitive, and motor, and we'll go through those. One big change is that these milestones include the age that most, defined by 75% of children, would be expected to demonstrate a skill. So previously, most milestones were based on the 50th percentile or an average. And I kind of showed you that bell-shaped curve before. So for example, it used to be thought that the 50th percentile for walking was 1 year. And so a parent or a pediatrician may be concerned if a child is not walking at 1 year. However, with this change with the CDC, it's kind of shifted to the 75th percentile, which, for example, for walking would be 18 months. So in this case, it provides a little more leeway. So a pediatrician or a parent may not become concerned if a child isn't walking now for 18 months. And again, that takes into account, more wide-ranging development and that bell-shaped curve. So here is a screenshot from the CDC on those developmental milestones. Just you can see, you can go into this website, CDC's developmental milestones, click on any of these and get an idea of how babies or children develop at all of these years. And I'll show you some examples. This would be what the child looks like at approximately 1 year. You can go on to see that. Just to show you a little more in depth, there are these nice checklists that you can download. And for example, in 1 year, we would expect for social emotional wellness that a child can play patty cake. From a language point of view, a child should be able to wave bye-bye for a year. If we look at cognitive milestones, child should be able to put something in a container. And if we look at movement and physical development, the child should be able to pull to stand and walk holding on to furniture. So the CDC website, again, most pediatricians are going to know these milestones, but it gives parents the ability to download these checklists and really try and determine if your child is developing normally. This is another example of milestone, social emotional milestones that were downloaded from the CDC website that was recently developed. And what I think that this graphic shows is that children develop in succession. You don't just, if you see here, a child will by 2 months smile, by 6 months laugh, by 12 months play a game of peekaboo, and by 18 months point to show interest. And so they don't just all of a sudden at 18 months start showing interest in pointing. They really have to take one step at a time. And for those of you who have children, it's really fascinating to watch your children develop. You see that even between these 2 and 6 month stages, there are many stages and steps that children take to get from one stage to another. So development is sequential. You know, you don't just start running at a year, but you take one step at a time in a very slow and methodical manner. And so I'm going to go through some of these milestones as described by the CDC, just so you guys have an idea of what children are expected to do. And again, if you have children at home and they're not doing some of these things, it's okay, talk to your pediatrician. Remember that development there's a wide range of development and what's normal. So when we look at communication and language, children should be able to make sounds other than crying by 2 months of age. They can make sounds back at you when you talk by 4 months of age, and then they can blow raspberries by 6 months of age, wave bye-bye by 12 months, call parents mama or dada by 12 months, and put 2 words together, such as more milk by 24 months, and then be able to talk in sentences with greater than 4 words by 4 years of age. So 4 is always an easy to remember. So 4 words by 4 years. In general, children are 40 pounds and 40 inches as well by 4 years of age. When we look at social and emotional development, children look at your face starting at about 2 months of age. And remember, these are all about the 75th percentile for children. They'll smile or get your attention by 4 months. They don't laugh until they're about 6 months of age. They'll play games like pat a cake by 12 months, clap when excited when 15 months, look at your face and decide how to react to a new situation by 24 months. And then again, by 4 years, a child will have enough social and emotional awareness to comfort others when they are hurt. When we look at cognitive outcomes or cognitive milestones for children, we know that children can watch you as you move by 2 months of age. So children before 2 months of age wouldn't expect to track you or follow you. They look at their own hands with interest when they're 4 months of age. They don't reach to grab a toy until they're about 6 months of age. Then they look for a toy that you hide by 12 months of age. This is important because then they have, an idea of reality, what's in front of them and what's not in front of them. By 15 months, children can try to use things right away, like a phone, a cup, or a book. They try to use switches, knobs, and buttons on a toy by 24 months. That's important when you're trying to do things like baby-proof your house. Again, you don't have to worry so much about a child grabbing something, grabbing a button, or grabbing an outlet if they're 4 months of age, but by 2, you really have to worry about that. Children by 30 months can follow 2-step instructions like put the toy down and close the door. And it's not until about 4 years that they can name a few colors. And then when we look at the last stage of development, which is motor development, this is probably what most people think about development, motor skills. So children can hold up their head from their tummy at about 2 months of age. They can hold their head steady without support until 4 months at 4 months of age. They can roll from the tummy to the back at 6 months of age. Again, some children will do this earlier. Some will roll from tummy to back at 3 months of age. And that's important to know if you're putting your child, for instance, on a changing table. That's when you start to worry about them potentially falling off as they roll over. Children can sit without support by 9 months of age, pull to stand by 12 months of age, walk holding onto the furniture by 12 months of age. And again, with these new guidelines, it's not until 18 months that children can walk without holding on. Some children can do that at 9 or 10 months. Children can drink from a cup at 18 months, And then, for example, use a fork at 3 years of age. And I think when you think about motor skills, it's probably the most easy to think in terms of how development is sequential. So babies have to, be able to hold their head up steady and support their head before they can sit. And then they have to sit before they can kind of get to a tripod and grab onto something and stand up. And then they really have to stand up holding on to something before they can walk. So again, it's a very sequential stage of development that kids go through, and probably best understood if you have kids in your home or grandkids in your home with them and you watch them develop. And then finally, the CDC milestones go through age 5. And so by age 5, children can hop on 1 foot, count to 10, answer simple questions about a book or a story, or follow rules or take turns playing games. And so here's the kind of the final checklist from the CDC and the AAP website about age 5. And again, looking at social and emotional awareness. Once again, children can follow rules, they can tell stories, count to 10. And so if you're interested really in diving deep into childhood development, it's really worth exploring the new CDC website. Or if you're, again, a parent, it's something that's really helpful to check your children's development. So when we think of what pediatricians do in development, again, there's developmental surveillance on top. That's going to happen every time a child goes to a pediatrician. There's developmental screening that's formally done usually at 9 months, 16 months, and 30 months. And at any time, if a pediatrician noticed that even by surveillance or formal screening, there's an abnormality, there's the possibility of the pediatrician or the family practitioner referring a child to services if they're concerned about a child's development. And the services that we're talking about that may potentially improve outcomes are listed below: speech therapy, occupational therapy, physical therapy, hearing, or developmental pediatrics. So that's development in a nutshell. I'd like to talk about, one important outcome of development, and that's school readiness. And so children develop to age 5, and age 5 is when kids go to kindergarten. And so being ready for school and having the milestones to thrive in school is just one really important thing that parents and pediatricians check for. So school readiness refers to child being ready to make an easy and successful transition to school. It includes both academics, attention, concentration, and physical skills. And it really allows teachers to expand development because without these skills, children will fall further behind. There are many building blocks of development that are important for school readiness. They include self-regulation. So children have to be able to maintain and change their emotions when they're in school. That's obvious why they have to do that. Receptive language, they have to understand what the teacher and other children are saying. Expressive language, they have to be able to tell the teacher what they're thinking. And then executive functioning is really higher order reasoning and thinking. And children have to have social skills. They have to be able to get along with other kids. If children have difficulties and they're not ready for school, it becomes very difficult to catch up and thrive in a school environment. So if kids don't have those building blocks, they may dislike school because they're frustrated. They may be rejected by their peers. They may have a very difficult time following instructions, have poor academic outcomes, or really develop a number of anxieties with the limitations that they have. So I'd like to break right now and show the video. Hey, Kate, can you show it? Because I'm not 100% sure I have the audio.
Oh, yeah, absolutely. Let me.
Or you want me to try?
No, it's okay. Let me pull it up. I just didn't pull your thing up because you were.
Okay, so while she's doing that, this is a video from 0 to 3, which I think explains really, it's about a 4 or 5 minute video, explains really well the steps that kids take and why it's important to, why school readiness is so important. Do you want me to try? Let me try since you don't have it up. If you don't hear.
Okay. Oh, there it is. I'm ready. Okay. I just got to get it.
I'll have to stop sharing, correct?
You will.
Okay. Now I can see everybody's faces.
Mm-hmm. All right. This is the video. Okay. Screen. Share sound. Okay, this is the video.
Yep, you can make it bigger.
Katrina watches proudly as her daughter Leanne begins her first day of kindergarten, her official entrance into the world of formal education. But of course, Leanne has been preparing for this big moment since the day she first opened her eyes. Babies are born learning. They are naturally curious and driven to make sense of their world. In order to be ready for school, children need to develop strong foundations in language and literacy skills, thinking skills, and social emotional skills. Language is a skill that allows children to communicate and connect with others. Using gestures, sounds, and words, children are able to share their thoughts and feelings. When you read and sing with your child, narrate as you go about your daily activities, and engage in back and forth communication, you build her language skills and help increase her vocabulary. And language provides the foundation for the development of literacy skills. You support early literacy skills when you share books and stories with your child. Let your little one hold the book, turn the pages, see the words as you read, and even tell you the story using his own words. You can also help your child make connections between the story and her experiences out in the world. Thinking skills begin developing in a baby's first days and grow in complexity as children explore and experiment through play. Babies begin by making basic cause and effect associations like, I press the button and the door pops up. As they grow, they master the logical thinking and reasoning skills that help them make sense of the world. Through everyday experiences, children also develop an understanding of math concepts, like spatial relations, sorting, and early counting skills. This happens quite naturally through play. For example, learning about big and small, and logical thinking while building a block tower. You can promote your child's thinking skills by using everyday moments as opportunities for learning. For example, your toddler begins to learn numbers and matching as you count out the fruit and point out which are apples and which are oranges. So how do social emotional skills lead to school readiness? In many ways. Take self-control, for example. Self-control enables children to do so many important things. Pay attention, wait, cooperate with others, cope with frustration, and resolve conflicts. Young children learn these skills through interactions with peers and through your example and guidance. What about self-confidence? Confident children are willing to take on new challenges, which leads to mastering new skills, a key ingredient for school success. Self-confidence is also crucial for learning to share, dealing with competition, and making friends. You build your child's confidence by pointing out his skills and abilities and encouraging him to muscle through difficult tasks. And the most important ingredient for helping your child be ready for school? You. You matter. When it comes to school readiness, you are not just your child's parent. You are also her first and best teacher.
Okay, thanks, Kate. Share my screen again. Okay, can you guys see that?
Not yet.
Not yet. Okay, should be able to see it now, correct?
You got it.
Okay, so school readiness, I thought that was a great video, and it really points out how learning and readiness starts at birth as a neonatologist and develops until the time you're ready for school. And so these are some pretty depressing data from Delaware about 4th grade reading. And so 3rd and 4th grade is a really important time. You have to be ready for school. And most educators think if you're behind by 3rd grade, children have a really difficult time catching up. So I think you can see my pointers. If you see these blue lines over time in Delaware, the blue lines are Delaware students in 4th grade who are below proficient reading level. That's about 70%. And if we look here at below basic reading level, that's about 40%. And that's increasing over time. So many children in the state of Delaware are behind in their reading levels by 4th grade. And at that time, it's going to be a very difficult time to catch up. So here's what I, at least personally, the last part think is the most important or interesting part of the talk. And that's, what influences development? And because there are really many multiple factors. And again, I'm going to take this from the perspective of a neonatologist who counsels parents after the birth of their children. Health and development is interactive and adaptive at multiple levels. Development is not static. It changes over time due to many factors. So your body adapts at a molecular level, at a cellular level, at an organ system level, and at a behavioral level. And development is inherently plastic. Again, it changes over time. There are many factors that lead to a wide range of outcomes, both positive and negative, and that's what we're going to talk about. And so there's a strong interaction between genetic predisposition for your outcomes and the environment. I'm going to talk about some research from Kimberly Noble, who's a researcher in New York, but she said it best is our experiences change our brain. And so this is a hypothetical graph that I made up of some developmental trajectories. And you can see here by the pointer, just imagine a baby who's born at birth, or a number of babies who are born at birth, who then go out into the world in a different time. And some babies may have an upward trajectory for their development by the time they reach adulthood. Some children may have a downward trajectory, and some children may stay the same. And so what are the things that may improve your development over time? There may be a certain genetic predisposition that helps your development. We know that wealth improves development, as does educational opportunity and certain parenting skills that we'll talk about. We also know that things adversely influence development. Certain genetic conditions do, but poverty, racism, certain negative parenting skills, toxic stress, a premature birth, or exposure to drugs before or after birth may also negatively influence development. And we'll talk about many of those things. The brain starts developing very early in the womb. This is a picture and a graphic that I think shows it very well. And if you look at the upper left-hand corner, at about 30 days of age, the brain starts to develop. We can take care of babies as low as 22 or 23 weeks gestation in the womb. And you can see here, at that time, babies have a very smooth brain. It continues to fold over time to what looks like, more of an adult brain by 9 months, or at the end of a full-term gestation. But then even after birth, the brain continues to develop and looks very different in a young child and a teenager, or in adulthood, or in an adult. So again, important to understand that many different things that can affect a child inside the womb or outside the womb after birth may affect their development. I want to talk about a few common disorders in pediatrics that are babies have development that's not typical. And the disorders I'm going to talk about are autism, and I'm going to talk about all these very briefly: trisomy 21 or Down syndrome, cerebral palsy, and then an environmental condition that causes a delay in development, which is lead poisoning. So I'm not an expert in autism because I take care of babies, but autism is a developmental disability that can cause significant social, communication, and behavioral changes. It can be detected by 18 months or younger, but really by age 2, the diagnosis is reliable. And it is, many pediatricians can say that they can detect it before 18 months, and many parents will suspect that their children may have autism if they have a child with autism before 18 months. The early signs of autism is that a child may avoid eye contact, have little interest in other children or caregivers, or have limited display of language. Autism is becoming more and more prevalent. The CDC estimates that 1 in 44 8-year-old children have been diagnosed with autism. That's 23 per 1,000 live births. We have about 6,000 births every year at Christiana, a little more. So that means 120 or 130 children who are born in a hospital every year will eventually have autism. It's 4 times more common in boys and girls. The cause of autism remains unknown, but we do know there are some risk factors. There are some genes and other conditions, such as something called Fragile X syndrome, which is when children are lacking a part of their X chromosome that is associated with autism. We know there's an increased risk if you have a sibling with autism or have older parents. And it's important to know that there's absolutely no link with autism and vaccines. One thing that we talk to parents all about is something called trisomy 21 or Down syndrome. And I think probably most of the people on the call know somebody with autism, or likely know somebody with Down syndrome, or have a family member who may have Down syndrome. Down syndrome occurs when there's an extra copy of chromosome number 21. So we usually have 46 chromosomes in our body. Children with Down syndrome have 47 chromosomes. And so they have an extra 21st chromosome. And this really changes how the body and brain develop. You can see some drawings here of a child with Down syndrome. They're very typical features that the baby has with Down syndrome. And we can usually, sometimes it's diagnosed by something called an amniocentesis before birth, by looking at the chromosomes, and sometimes it's diagnosed by just looking at the baby's facial and physical characteristics. So babies, when they're born with Down syndrome, have a short webbed neck, you can see on the right, have a tongue that protrudes out a little further, have a single line across their palms. So if everybody looks at their palms, you usually have a couple lines across your palms. Babies with Down syndrome have a single palmar crease, although some people who without Down syndrome have a single palmar crease. So don't worry if you see only one line across your palm. Babies have low muscle tone when they're born with Down syndrome, and this occurs about 1 in every 700 babies. So again, pretty common. We know that women who are over 35 are at increased risk of having a baby with Down syndrome. However, most babies with Down syndrome are born to women less than 35, and that's because most babies are born to women less than 35. Babies or children with Down syndrome have, the IQ is usually in the mildly to moderately low range, and babies are slower to speak than typically developing children. So if you have a baby known to have Down syndrome, a pediatrician is going to watch and look at that baby very differently for their development. For example, this is a growth curve that was made specifically for children with Down syndrome. So we know that babies or children with Down syndrome are going to grow a little bit differently. So we wouldn't plot them on a growth curve of a child without Down syndrome. Cerebral palsy is another childhood disorder. And cerebral palsy is a physical disability that affects movement and posture, most common, and it's the most common physical disability of childhood. Cerebral palsy usually starts in the area of the brain that controls the ability to move muscles, and some children also have cognitive delays associated with the motor problems. Cerebral palsy can be mild or severe, and it usually manifests in a delay in motor milestones. And so I went through development before. A pediatrician is probably not going to develop this until you start to see if a child can sit up, if they can walk, if they can pull to stand. It's important to know that it's static. It doesn't get worse over time, but it's usually not diagnosed right away because, again, you have to watch a baby's motor skills or child's motor skills develop to make this diagnosis. I thought this infographic of cerebral palsy was really explained it pretty well. There are many different types. The most common type is spastic cerebral palsy, where the muscles are very tight. It can affect either 2 or 4 limbs of the body. For instance, if it involves the right side here, that's called hemiplegia. So hemiplegic cerebral palsy. It can be very mild, where children can walk up steps, or it can be very severe, where children are wheelchair bound. If you look at the bottom here, there are many associated impairments with cerebral palsy. 1 in 3 are unable to walk, 1 in 4 are unable to talk. 1 in 4 have bladder control problems, 1 in 5 have sleep disorder problems. So it always involves the motor system, but there can be other associated problems as well. And I'll show you some pictures of babies who we take care of here, and some x-rays. This is one disorder that we really worry about when a baby has a brain injury after birth. Lead poisoning is an environmental exposure that can lead to adverse development in children. We know that lead poisoning can cause damage to the brain and nervous system, learning and behavior problems, hearing and speech problems, and lead poisoning can be very difficult to diagnose because there are usually no immediate symptoms. It's most harmful when children are exposed less than 6 years of age, and typical exposure sources are paint in homes. And so when homes were built before 1978, leaded paint was used, as was the case recently in Flint, Michigan. Lead can be in the drinking water, or it can be in other consumer products and come from overseas. So because there are usually no immediate symptoms, the American Academy of Pediatrics recommends screening children at 12 to 36 months. If 27% of the housing is built before 1950, or the prevalence of blood lead concentration is 10 micrograms or 12%, or in 12%, let's just say, or greater of the population. And so that's the American Academy of Pediatric recommendation. Most children in the state of Delaware are screened for lead poisoning at about a year of age because of this. This is a graph that shows the typical sources of lead. Most come from dust lead, from housing paint. Some can come from water, as I mentioned, and it can also come from soil and house renovations as well. The guidelines for intervening for lead poisoning were recently changed by the CDC and by the American Academy of Pediatrics. And so this is a graphic I think that's really interesting. So children are screened at 1 year of age. There's a law that's coming up in Delaware that also recommends repeating at 2 years of age. And some form of intervention is recommended if the blood level is greater than 5 micrograms per deciliter. And by the way, children should have a blood lead level of 0. And what this shows is if in the blood level greater than 5 has kind of an average IQ loss of 6.1 per child, this would affect 3.1 million children throughout the United States. But if you go down even lower with blood levels, for instance, 2.10 micrograms per deciliter, this would affect 5.7 million children, and with an estimated IQ point loss of 9.3 million. So again, because if we go down lower and intervene with lower levels of lead, will kind of affect more children with less, severe disabilities. The idea was recently changed to go down before lower than 5 micrograms per deciliter to kind of intervene in more children who may have less deficits from lead, or smaller deficits from lead screening. Okay, so that's lead. One of the things that I deal with all the time as a pediatrician is babies who are exposed to opioids. It's become a very big problem in the state of Delaware and nationally as well. So I want to talk about that for a few minutes as well. We know that when moms take opioids, those opioids cross the placenta, and those opioids can cause, when babies are born and when the placenta, the umbilical cord is cut and babies are no longer exposed to opioids, that can cause withdrawal in the babies. And that's because the babies' opioid receptors are saturated and they're no longer exposed to opioids. So there are many different symptoms that babies experience, such as increased stress. Hyperphagia is increased eating. Babies who are withdrawing eat a tremendous amount. You can see here they have a decrease in their serotonin. They have sleep deprivation and sleep fragmentation. And I won't go through all of this, but babies can be very symptomatic if they're much like adults, if they're withdrawing from opioids. This is a graph of the number of babies we have at ChristianaCare with opioid withdrawal, and the left axis here is a number. The x-axis is time, the y-axis is just a number. The bottom here are the number of babies we've had at ChristianaCare every year with opioid withdrawal. You can see we peaked in 2018 with about 239 babies. Last year, the numbers have finally started to go down to 158 babies. And these are the number of patient days we have from opioid withdrawal syndrome. So you can see in 2020, there are 4,500 patient days here at ChristianaCare for opioid withdrawal. So a big concern for the babies here. not only is the exposure to opioids a potential concern for the baby's brain development, but we know that when moms use opioids, there's a lot of codependency. So they're also likely to use tobacco, marijuana. 13% of our moms, and this data a few years old now, used cocaine, SSRIs, which are antidepressant, benzodiazepines, and alcohol. So when we talk about the adverse effect of opioid exposure in utero, it's also very important to know that most moms don't use opioids. There are many other substances they use as well. So NOWS is neonatal opioid withdrawal syndrome. And so there's a lot of concern about the baby's neurodevelopment if they have NOWS. The long-term studies looking at outcomes of babies exposed to opioids are very difficult to tease apart because there are many environmental effects and they're direct in utero effects. And so think of a baby who may be exposed to drugs in utero for 40 weeks or for 9 months. That is not a good thing, but they also go home to very chaotic environments for 18 years, which can also affect their development. So there's also concern for long-term exposure that we have to give babies morphine and other drugs such as phenobarbital to treat their symptoms. There's concern about the developmental effect of that. And so we know when babies are born to moms who are on opioids and we have to treat them with medications, it's really important to provide them with comprehensive services for both mother and baby when they leave the hospital to maximize their development. And this includes social support, parenting intervention, and maternal treatment. So we try and provide all these things for mothers as well. I also want to talk about the concerns for marijuana use during pregnancy. Now, opioids are something that you read about all the time, but it's more common for moms to smoke marijuana before and after pregnancy. We know that marijuana crosses the placenta and can cross into breast milk as well. You can see in this graphic on the right-hand side here, there are many different areas of the brain that marijuana affects. It affects the developing brain, and I showed you guys before the picture of how the brain develops in the womb and after birth as well. Marijuana contains almost 500 chemicals, including THC. And so there really is concern for long-term development of the brain, including memory and learning and behavior, if babies are exposed to marijuana in utero, or if children use marijuana as well. So we think of it as a drug that's, pretty benign and used pretty commonly, but important to know that there are potential developmental effects of marijuana. And I just want to show you some data about how commonly it's used. This is a study that was from the American Journal of Obstetrics and Gynecology in marijuana use in pregnant and non-pregnant patients. It was from the National Survey of Drug Use and Health from 2007 to 2012. And so that's a few years ago now, but at that time, 3.9% of pregnant responders reported use in the last month. So about 4% of pregnant mothers are using marijuana, as compared to 7.6% of non-pregnant responders. So, about half mothers who use marijuana quit during the pregnancy, but again, about 4% are using it. And so when you think of about 4 million births in the United States every year, 4% of 4 million is a lot of babies potentially exposed to marijuana. And out of those 4% of mothers using marijuana, 18% were chronic users or heavy users. This is another study that came from Colorado, something called the Pregnancy Risk Assessment Monitoring System that almost every state does in 2015. And again, Colorado was the first state to legalize marijuana. 5.7% reported use during pregnancy. And early postnatal use in women likely to breastfeed was reported as 5%. And in this study, marijuana use was associated with increased odds of the baby being born low birth weight. In this study, marijuana use was more prevalent with younger, maternal age, lower education, Medicaid, and lower income, and white race. And so again, opioid use, marijuana use, when we think about that trajectory that I showed you, are two things that could potentially negatively affect baby's trajectory. All right, there are too many of you guys on the phone here to ask a history quiz. But I'm gonna give you a pause to look at this picture and see if anybody who knows what this picture is. Probably only gonna know it if you guys are a little older than high school age or college age. And I know there are many people out of college and older this talk, but this was 1963, and this is John Kennedy. And in 1963, John Kennedy had a son named Patrick, who was born at 36 weeks and had respiratory distress syndrome and died. This was the president's baby in 1963, the same year that John Kennedy died. At that time, we didn't have ventilators for babies. All that could be done was to give oxygen. There was talk of sending the baby to Canada, where a woman named Maria Delavoria Papadopoulos in Toronto was first starting to put babies on ventilators. However, it was, felt nobody wanted to send the president's baby of the United States outside of the country to receive that treatment. And the reason I show you guys this slide in this time is this is what really started the field of neonatology when the president's son died, who was born just 4 weeks early. We would really not think of a baby born 4 weeks early being at risk of dying now. And so it wasn't until the 1970s that we started keeping premature babies alive. However, since that time, we've really revolutionized the field I'm in. And so we have many babies who are born prematurely who survive. So I want to just show you this recent study on really small babies and their outcomes. And because anytime babies are born really early, we worry about how they're going to do in the long term. So this is a study that was recently published in 2022 in outcomes of babies. And these outcomes are assessed when babies are about 2 years of age. And if we just look at the left here, on the x-axis, is the gestational age, and the x-axis is the percent of children who have these outcomes. And these are babies born at 22, 23, 24, 25, 26 weeks gestation. Now, Patrick Kennedy, as I just told you, was born at 36 weeks gestation, almost 2 months later. And so 22, 23 weeks gestation is the smallest a baby can be and survive. And we can see here, these dark blue bars are babies who survive with severe neurodevelopmental impairment. We can see on the right here, this is death. So a lot of babies who are born at 22 or 23 weeks die, but of those survive, almost 40% or 50% of the babies who were born at 22 or 23 weeks will have a severe neurodevelopmental impairment at age 2. And that's generally defined as blindness, deafness, or cerebral palsy, or a significant delay in their cognitive outcomes as well. So premature birth is one of those things, again, when we think about the trajectories that can negatively influence babies. And so one of the reasons that when babies are born early, they have a high risk of these delays is they have very high risk of bleeding in the brain. And so this is a specimen from an autopsy of a very premature baby, and you can see the brain is very smooth here, like I showed you in the pictures. In the middle here is a typical hemorrhage that a baby has in their brain. So let me show you some images that we look at when we talk to parents about what to expect when they're born. This is another premature baby who's born. This is an ultrasound of their brain. And so typically we'll do an ultrasound of a premature baby's brain in the first week of life to look for bleeding. And then subsequently we look at them at about a month of age. And so this ultrasound, this is something called a coronal view. And so imagine that this baby is kind of standing up and facing all of you. And so this would be the right side of the baby. This would be the left side of the baby. And I think you guys can see my pointer here. This area in the middle that's dark are called the ventricles. That's a normal area that collects fluid. But these areas next to the ventricles up here that are dark are not normal. And those are cysts that have formed in this area from either bleeding that occurred after birth, or sometimes babies have these cysts without bleeding. And the reason that that is really important is we know that something called the long motor tracts, nerves run from the top of the brain right through that area where you saw those cysts form down to the arms and the legs. So we know that if we see that ultrasound after birth and babies have those cysts right in that area, they're at very high risk specifically of having cerebral palsy or problems with their motor development, problems walking and talking. Problems walking or sitting up. And so we may not see those changes I've explained before until you watch children develop over time, until they're 4 or 6 months or a year of age. You won't see any changes in the physical exam of a baby, but you'll see it later over time. It's also not uncommon for a baby to have a stroke. And so this is a MRI of a baby who had something called a right middle cerebral artery stroke after birth. And so this is if a baby, this is a little different view of a baby. It would be as if they were lying down with the feet facing you and the head in front of you. So imagine you're looking at the foot of a bed up, and the head is kind of on the pillows, and you take a slice through the brain. That's what this looks like. And so this is the right side, and this is the left side. And you can see this white area here that we see very on is a very large area of stroke in a baby. And so this is the kind of thing that we'd have to talk to a parent about what to expect when the child gets older. That can be very hard to predict. Now, one thing about babies, I mentioned their plasticity, or I mentioned plasticity of development. If an adult has a stroke, it can be very hard to recover an area. We've all learned to walk in one area, or have motor skills in one area of our brain, speech in one other area. It's very hard to recover those skills, but in a baby, as they grow and develop, one area of the brain may compensate for another and take up the skills where one other area of the brain is not capable. Here's another baby who had a left middle cerebral artery infarct. So here's the right side, here's the left side. You can see all this large white area here is a large stroke that a baby had, involving much area of the left side of the brain. And so we'd be very worried about this baby's motor development, potentially their cognitive outcome. But again, very different than an adult, babies can recover over time and do very well. This is another MRI of a baby's brain that I'll show you here. Again, very similar view as if you're looking from the head of the foot of the bed up to the head of the bed. And so this is the right side and this is the left side. And you can see these bright areas on the MRI that are in something called the basal ganglia. And this is a baby who had a very difficult birth and lacked oxygen at birth, that we would expect potentially that this abnormal MRI and those events at birth would have long-term ramifications for the baby over time. And then we have a lot of babies who have birth defects of their brain as well at birth. And so this is something called holoprosencephaly, alobar holoprosencephaly. This is another MRI. It's a different view. It's like we're looking at a profile view of the baby. And you can see that this baby has just a very thin cortex of brain, and this area behind the brain is all fluid. And so when we would see an MRI like this in a baby, we would expect and counsel the parents that a baby like this would have significant problems with their development as they got older. This is another birth defect that a baby has, another MRI. This one is a little more subtle. This is something called Schizencephaly. We can see you can see the right side of the brain over here and the left side of the brain look a little bit different. And this clefting that we see on the right side of the brain is an abnormal development of the brain that is something associated with seizures and other medical problems and developmental delay as the child gets older. And this is something called an Occipitalencephalocele. It's an extreme form of birth defects. Again, a profile view of the baby. You can see there's a sac behind the brain and a small amount of brain that's in the sac that the baby has, that once again, we know is associated with problems with development. And so as a neonatologist, when parents are born with this, we spend a lot of time talking to parents about what to expect as that child grows older and develops. One of the other conditions we can see in the newborn is if a baby has an infection. And so this is a recent baby we had with meningitis from a bacteria called E. coli. Once again, this is an MRI. This is a different view. This or similar views again, as you're looking at the foot of the bed, looking at a baby. This is the right side. This is the left side. And once again, we can see all these areas here that are almost like holes in the brain. And once again, something that we'd be very concerned about the baby's development. And then lastly, I'll show you here an MRI, a number of MRIs. We have a baby where they have areas of calcium buildup in their brain. And everybody probably remembers a few years ago, the Zika scare, where the Zika virus was really concerning for causing microcephaly, which is small brain or calcification in the brain, mostly in South America. This is a case we really thought had Zika because it had these very typical characteristics of a small brain, and these bright areas here and here are calcified, but we were never able to show through other testing that this baby had Zika virus. But again, many babies throughout the world were born with this condition that affected the brain that you would expect would certainly influence their outcome as they got older. Just to briefly go into treatment, this is something I wanted to share with you guys that's really novel and developing, and that's the use of umbilical cord stem cells, I should say, to treat these kind of lesions. So very scary for a parent if we see one of the typical MRIs that I just showed you and that a baby has a brain injury at birth. We know that even the many tissues, including the lung and the heart, can continue to heal themselves over time. And we know that there's stem cells that are within the brain, but there are also many, many cells in the blood from the umbilical cord that are stem cells that can then turn into many other cells. So that what I want to share with everybody is that there are multiple ongoing studies now to harvest stem cells from the umbilical cord. And if you see this type of brain injury in a baby, to spin down those stem cells, provide those stem cells, hoping that they'll go to the area of the brain that's injured and kind of regenerate the part of the brain that's damaged. So something that's really cool and developing. All right, so let's switch gears a little bit now. We talked about brain injury that I see as a neonatologist, and we talked about many other developmental disorders. But I want to talk now a little bit more about what's going kind of on in the neighborhoods and in our environment, and the kind of thing that really are beyond the healthcare system that can influence development. And I want to talk first of all about stress. And this is kind of a typical or normal stress response that I want to go over. I mean, everybody on this phone call has been stressed at one time or another. Probably many of you guys are stressed right now. People may have a test tomorrow or a test the next day or a test the next week. And some stress is normal. So when we look at stress, we think there's some benefit to stress, right? You think I have a test next week, or I have a big soccer game next week, or whatever it is, and you get ready for that. That stress motivates you to study, or it motivates you to practice more for soccer. It motivates you to practice more for a debate tournament or whatever it is. And ultimately you get better. But if it gets to the point where the stress is so high, it starts to have a negative benefit. If you're not sleeping, or you can't eat, or if that has other health effect, it has a negative effect. So when we all have stress, there's a normal stress response, and that's we release something called cortisol, which is a hormone from our adrenal gland, or epinephrine or norepinephrine. That's adrenaline that's released from our adrenal gland in our brain, and other things like cytokines. Cytokines causes our brain to it causes inflammation in our body. So it's really the brain that is the control center that senses and stress and regulates stress. I mentioned there's short-term benefits, but if you're stressed over and over again on an ongoing basis, day in, day out, hour after hour, there's long-term harm and chronic disease that occurs from the wear and tear on the body from stress. I don't know why this red line is here, but we'll go through it if you guys can see that. So I want to introduce everybody to the concept of allostatic load. And allostasis is the ability of an organism to achieve stability through change. So we all have allostasis. We all change in response to stress on our body. Allostatic load reflects the cumulative effects of experiences in daily life that evolve ordinary events. However, when environmental stressors exceed an individual's ability to cope, they become damaging. So if their stress response is repeatedly activated and the buffering effects are not adequate, there's this allostatic load. And so another simple way of saying that is some stress is good, too much stress is really bad and can affect health and can affect development. So one of the stresses that affects development that's been coming up in the recent literature time and time again is racism. And we know that there are disparities in outcomes between Black and white children, and racism has been one of the things that's been pointed to as potentially causing those differences in outcomes. And racism can be institutional or structural, or interpersonal. And so if children or adults are exposed to constant presence of racism, that increases their stress and their allostatic load and affects their health. I want to talk a little bit about residential segregation. And we know that in the 100 largest US metropolitan areas in the United States, 67% of the Black population and 58% of the Latino and 53% of Native American children, I should say, reside in low or very low opportunity neighborhoods compared to only 20% of white and Asian children. And so these are very stressful neighborhoods to live in, again, potentially increasing the allostatic load. We know that differences in neighborhood quality lead to adverse living conditions and concentrated poverty, such as poor schools, lack of grocery stores, adverse living conditions, access to healthcare, targeted advertising for tobacco and alcohol, gun violence, and pollution. So all these things are kind of chronic stressors that affect children over time. If people want to read more about kind of structural racism over time, I really recommend reading this book called The Color of Law. It points out many aspects of structural racism in our population. Back to history, the TVA, which is the Tennessee Valley Authority, was something from the New Deal in the 1930s that provided a lot of jobs to people in the United States. However, no African Americans were permitted to work in supervisory roles. In other words, they had lower salaries. Redlining was a common practice up through the 1950s, and redlining did not allow certain people who lived in certain inner city neighborhoods within those red lines to get loans, and therefore they couldn't buy houses and build generational wealth. So I won't go through all of these aspects, but again, there have been many policy aspects that have shaped cities and neighborhoods over time that shape outcomes, and they're subsequently shape development down the road. I mentioned Kimberly Noble earlier in the talk, and this is just want to show you some of her data. And again, she's from Columbia, New York, and she's done these really elegant studies in children over time, looking at their development in relationship to poverty. So here's some of her studies from 2007 on the left. And if we can look at all these different studies, she looked at something called socioeconomic status index. And so the higher the SES index, the higher the family wealth. And then she looked at things like perception of spatial relationships in children, language skills, memory of facts and events, cognitive control, and short-term memories. And you can see as wealth goes up for the children's families in all of these cases, these skills, these developmental skills increase. And the other way of saying it, as the socioeconomic status went down, these skills decrease. She subsequently did a number of studies looking at brain MRIs in children's related to income. And she was able to show that kids from poorer, less educated families had thinner regions of their prefrontal cortex, that's the front of the brain, and that higher family incomes were associated with overall larger brain surface area, and that children from households below federal poverty level had 8 to 10% less gray matter. So again, kids who grew up in poverty, that adversely affects their neurodevelopment, and in these series of studies shows that it adversely affects their brain volume as well. When we look at poverty in Delaware, and these data are from the University of Delaware Center for Community Research, children are the most likely of any age group to experience poverty, with a 5-year rate of poverty of 17.5%. Black Delawareans are more than twice as likely to live in poverty than white Delawareans, 18.6% compared to 9%. And Delaware cities have the highest poverty rate, with Wilmington and Dover having the highest poverty rates compared to other areas of the state. So again, poverty has a potential effect on development. Wilmington, Dover, highest rates of poverty. And this is another way of looking at poverty in census tract by Delaware. And this map just showing that the city of Wilmington has the highest concentration of poverty in Delaware. And so children growing up in these impoverished environments in the city of Wilmington would be expected to have potentially adverse development based on that. This is the child poverty rate in the United States, 18.5% compared to some of our neighboring states. So you can see Delaware, we have a little lower poverty rate than the United States, but higher than our neighbors in Maryland, New Jersey, and Pennsylvania. This is a picture that I think illustrates the effect of poverty in children really well. And this is from the Delaware News Journal in 2012. And it happens to be when my son, who's now a reporter, was doing an internship with the News Journal, Jesse Paul down here. And I'll just read the caption for you all, because I think this picture just really shows what children in Wilmington are exposed to. So Mohammed Chowdhury, owner of Bill's Meat Market, cleans glass broken by gunfire that killed a teenager a few hours earlier in front of his store, as a young boy approaches him and asks to purchase some donuts. So again, this is a shooting in the city of Wilmington. Kind of the police came by, took the body away. The fire department came by and hosed down the sidewalk. Everybody left, and then this child came back by, to buy donuts through the broken window that was shot out by the glass just a few minutes later. And it's almost as if it was nothing. And again, it was something that children in the city of Wilmington are exposed to all the time. When we talk about poverty and outcomes in development, one of the classic studies that was done many years ago, looking at why poverty may affect brain development, was this study that was done by Hart and Risley in 2003. And people may have heard of the 30 million word gap at age 3. And so what these researchers did was go into households and put in recording devices and look how many words kids were exposed to over time and extrapolate the number of words they would be exposed to by age 3. And we can see on the graph on the right, families who had professional parents compared to working class parents compared to parents who are on welfare were exposed to many different number of words over time. And the estimate is that children who lived in the poorest houses were exposed to 30 million less words by age 3 compared to families who had more professional parents. So this is pretty astounding data about exposure to words that can affect development. And so in the last few slides, we'll talk about some things that could potentially be done about development. This is a sign that a picture I took in Ithaca, New York, where the whole community had a program to enhance reading for that reason. Spread the word, every baby, every day, talk, sing, read, and play. So exposing children to as much language and reading as possible and as little screen time is something that can improve their development. These are two of our pediatricians at ChristianaCare having a good time with a Dr. Seuss book. And this is a program called Reach Out and Read. So in many pediatricians' office, for the same reason, pediatricians will give out books to children and to families to enhance reading and again, expose children to languages. And then one really incredible program in the state of Delaware is the Dolly Parton Imagination Library. So the Dolly Parton Foundation, along with the state of Delaware, has teamed up to give a free book for every every month for every children up to age 5. So when in most hospitals in Christiana, including ChristianaCare, we will sign babies up for these programs, and they will get a free book every month. So that's 60 books for a baby who's born in the state of Delaware. And this is just a great program to enhance learning and potentially language development in the state of Delaware. And remember back to that number I showed you guys before, where very high rate of children behind in their reading skills by 3rd grade. So this is one way to try and catch them up. And then many people have probably heard of the benefits of early childhood intervention or early childhood education, things like Head Start. There's been a lot of funding for Head Start in this country. So this dates back to something called the Abecedarian Project that was done in North Carolina. And these are pretty remarkable outcomes. That's why I want to go over them. And so we know that in this study, what they did was they provided early childhood education in early infancy until age 5 to a group, and they compared it to a control group of children who didn't get this early childhood education. And this was in the years 1972 to 1977. There were 111 children enrolled in that study. In these days, in 2022, we have studies with many more children, but in the 1970s, this is how studies were done. In this study, through age 15, the IQ scores were higher in the treatment group. In other words, the children who got early childhood education maintained higher IQ scores through age 15. The mothers of the treated group were more likely to finish high school. So the mothers didn't get the intervention, the children did. However, by intervening in their children, it improved the outcomes of the mothers. And at age 30, the treated group were more likely to hold bachelor's degrees and hold a job compared to the control group. So again, the effects lasted age 15 and age 30. And there were health effects as well. So those children who were in the treatment group compared to the control group had ultimately lower obesity, lower blood pressure in their mid-30s, and a lower risk of heart disease. So really long-lasting effects of early childhood intervention in this group. And this is where the idea for Head Start and early childhood intervention came in this country. And then lastly, I saw a few of you guys at the University of Delaware who were there. Just want to show you some really cool stuff that's going on at the University of Delaware. This is something called the Go Baby Go cars that were developed there. This is a really young child who was given a motorized vehicle. The reason to do that, this is a child who has motor problems at birth, something like cerebral palsy, like I was mentioning. And so we know that children who have motor problems have difficulty ambulating and getting around. And that doesn't only lead to motor problems, but leads to problems with the children exploring their environments. If they can't walk, if they can't sit up, they're not going to be able to interact with their parents, their aunts and uncles, their siblings in the same way. And so the thought is by allowing kids to be more mobile with these cars, it will actually improve their cognitive development as well. And this is another great program at the University of Delaware too, where they've taken children who have some upper motor problems with their arms and their legs. They may be born with a problem where they can't move their arms and the legs. And they fitted them with these garments that are almost like an exoskeleton that allow the children to much more easily raise their arms. And the reason that's important, again, is that allows them to explore their environment. And not only, we know that this is a child who might have some motor delays from their birth defects, but this allows them to really potentially reduce the cognitive delays as well by allowing them to explore their environment. So really interesting, novel things going on at the University of Delaware. All right, so I'm going to conclude and then, happy to answer questions that people have. It's important for parents and pediatricians to understand typical development. As I mentioned before, development occurs in stages. There's a wide range of what's normal, but there are many factors that influence the trajectory of development that I talked about. There are newborn conditions such as Down syndrome. They may influence development, substance use before or after pregnancy, premature birth, poverty and racism. All these things can change a child's trajectory in their development. Some solutions for improving development are simple, like early childhood education, reading to your child, decreasing screen time, and some solutions like decreasing poverty are not so simple. And with that, I'd like to thank everybody for their attention. I'd love to take some time. Looks like we have a good amount of time to answer questions.
And we have some. All right, first question that came down the pike. Yes, my baby's on. Are there a unique set of screenings for children learning American Sign Language as their first language? We've seen a lot of the deaf community recently in the news.
That is a great question. I wish I knew the answer to that. I mean, we clearly know that if children are deaf, that may affect their the development. We also know that every child in the state of Delaware has a hearing screen before they go home, and that's done because we know that the sooner we intervene with those children, the better their outcomes. And so we want to try and make that diagnosis certainly before age 3 months or 6 months if possible to try and intervene. I don't know of a separate developmental screen. There might be one, but again, important to make that diagnosis, intervene early to prevent adverse outcomes. It is one of the things that we would expect may influence a child's development.
What about children of deaf adults? Is there anything different that you do for them?
again, just to be cognitive that that's the case, and you may have to work harder to expose children to language in other ways. And anecdotally, I do have a first cousin who's deaf, and his wife is deaf, and his children are all hearing, and they are typically developing. Other than being cognizant about it, again, exposing your kids to as much language as possible. No.
All right.
Go
ahead.
Those are really excellent questions.
Someone would like you to review your career journey. How many years did you spend on each step since high school, and what was your biggest issue?
My biggest issue.
That's what
So it's a long journey as you went through. After graduating from college, medical school is 4 years, and then you do a pediatric residency, which is 3 years. And then to do a neonatology fellowship, it's another 3 years. So it's 10 years of training after college. And for those of you guys going into it, that seems like a long time. It seems like a lifetime. And it seems like impossible to do that. Medical school is financially a lot of money, and you do get paid as a resident, you do get paid as a fellow, but not a lot. But when I look back on it now, and I've been practicing for 30 years, that 10 years doesn't seem like a long period of time. And so when you're older, you have a very different perspective. And so I wouldn't be scared of that time commitment over time. Seems like a lot at the beginning. Looking back on it, it's not. It was well worth it. The biggest challenge is you have to stick to it. You have to be really focused, and you have to work. I mentioned I was just an average student in high school, but at some point you have to work really hard and be focused on it. So I was in high school. I was as a medical student. I was as a resident, and as I was as a fellow, and I'm a lifelong learner. I'm still learning. And so when I'm on call now, I sleep in the hospital. That's what I do in call, to take care of babies in intensive care unit. But I love it. It's hard, but it's very rewarding. And so I think the hardest thing, is just sticking to it and working hard, but it's worth it.
What was your undergrad degree in?
My undergraduate degree was in biology. And so I took a little different path in biology. I mentioned I went to the University of Colorado. There were 2 different biology degrees there. So there was something called molecular and cellular biology, which most people who were pre-med took. And there was something called environmental biology, which I took. And I just thought it was a little more interesting at the time. It was more focused on ecology and less focused on molecular biology. And but I studied biology basically.
All right. Can you speak to how babies are impacted by things like Pitocin via breast milk and colostrum after labor and delivery, or via a mother's IV during labor and delivery? How can newborns be impacted by that type of thing?
So we think that Pitocin affects mothers. It's a hormone that's beneficial to mothers and to mothers' well-being. It doesn't affect babies so much, but I didn't mention breastfeeding. I should have. We know that there are many health effects of breastfeeding. There are studies that show cognitive benefits to babies if they breastfeed, meaning benefits in their intelligence. Those benefits are relatively small, meaning if you look at children who are breastfed compared to formula fed, there's about a 4 or 5 IQ point difference in their outcomes. That's not major at an individual level, but it's major at a population level. And so, there are many health effects to breastfeeding. It decreases obesity in children, it decreases hypertension, and it does have some cognitive events. So breastfeeding is something that mom can do very early on to improve the outcome of their children, has potential beneficial effects. It's also not the end of the world if you can't breastfeed. There are many intelligent children who are bottle fed. And again, at an individual level, small effect. At a population level, if many, many children benefit, breastfeed, that has a big effect on kind of societal outcomes.
Okay. Next question. Twins are often born early and smaller than single babies. How do neonatologists and pediatricians assess development for these children?
Good question. So twins are oftentimes born smaller. There's kind of not enough room in the uterus, for growth of two twins. So sometimes both babies are born smaller. Sometimes one baby is born smaller. Typically, if a baby is born smaller from being a twin, we don't think that really is going to have a major effect on their outcome. I mean, especially if the twins are identical, you can think of the two twins having kind of the same environment. They're going to go to the same house. They probably have the same genetic composition. And what probably has made them smaller is just some restriction of their growth due to the placenta in utero. And so it's probably not going to have a major effect on their brain development when they get bigger. So we can be very, positive with a family if one baby is smaller just because they're a twin, and the one twin is smaller maybe because their growth was just squeezed out a little bit. On the other hand, there's some babies who are born very small because they may have an infection like Zika virus that I showed you. And that wouldn't be a twin that we really would worry about their development. There's some babies who are born small because they have an abnormality of their chromosomes where we would worry about their development. Probably the most common reason we see babies who are small now is something called preeclampsia. And so preeclampsia is a disorder where mom's blood pressure goes up during pregnancy. And that can over time affect the blood flow to the placenta and the babies get smaller. Again, we don't think that unless they're born extremely prematurely from that, which sometimes they are, that's going to have a major effect on their outcome over time. It will potentially have effect on their growth. So if babies are smaller at birth, in general, they're smaller as adults. And generally, they weigh less as adults. And so one example would be is if you would take, one baby who's small at birth, what we call growth restricted, compared to their siblings, they may be 2 inches shorter or 10 pounds lighter as an adult, something along those lines. So not a major effect, but some effect. And so I generally don't tell parents that if parents aren't born, if baby's born a little small, I'm not going to worry them after birth to say your baby's going to be 2 inches shorter or 10 pounds lighter. If they ask, they will, but I think that's not a concern to most families.
I think I have time for one more question. Dr. Paul, what we've been doing is I still have another 6 questions to ask you. Would it be okay if I just emailed the questions to you and you can just write a response and we'll put it up on the website?
Of course, yeah.
Okay, so the last question that I have out loud is, does chronic stress affect babies in utero?
Chronic stress of the parents. That's a really good question. I don't think we know the answer to that, but the answer is probably in some way it does. And let me go back to the previous question when babies are small, and this is a good way to end the talk because it's really pretty fascinating. And there's something called the Barker hypothesis. And the Barker hypothesis is that in utero stress may potentially affect babies' metabolic programming later on. And so we know that babies who are tremendously growth restricted at birth, I mentioned the weight, they are at increased risk of things like diabetes and hypertension and obesity as they get older. So, everything has an effect. And so it's hard to quantify exactly how chronic stress may affect a baby. But if it gets to the point where the baby's really growth restricted, it may affect their growth, as I mentioned, and it may affect their metabolic programming later on. And so they may be at increased risk as an adult. Now, if you guys have had babies who are smaller, I wouldn't worry about it. Again, these are population levels. These are like risks. So the risk might be slightly increased. And you have to kind of look over the millions and 4 million babies who are born every year in this country to show that those babies who are smaller maybe have a slightly increased risk of diabetes, hypertension, and those kind of things. So there is potentially an effect of chronic stress. Again, those studies are hard to do. Probably more effect of chronic stress directly on an individual than through the a mom through the baby in utero, if that makes sense.
Well, that's amazing. Thank you so much, Dr. Paul, for your presentation and for taking the time out of your evening to chat with us tonight. As I said earlier, the recording of this lecture and Dr. Paul's answers to the questions will be on the website. I have already sent out the survey to everybody, so you should have received an email from me. Please fill it out, and thank you all for coming. We hope to see you next time, and have a lovely evening.
Yeah, thank you, everybody. Appreciate everybody's attention. Thanks.